Good afternoon. I want to welcome you here on behalf of Project Firstline Rhode Island. This is our fourth webinar in our Preventing Healthcare Associated Infection series, Preventing Clostridioides difficile infections. So this session is brought to you by Project Firstline Rhode Island under the Center for Acute Infectious Disease Epidemiology, the Rhode Island Department of Health, in partnership with the CDC. Again, thank you for taking the time to join us today, and thank you for the vital role you play in healthcare. Again, one more reminder, if you haven't done so already, please take a look in our chat. Our project assistant, Abby, has been posting the link to our pre-session survey, so go ahead and do that. Before we get started, that will close a few minutes into the webinar. At this time, I'd like to have Dr. Alexis Kearney come on and introduce herself.
Good afternoon, everyone. Thank you so much for being here. We are really excited to be here. We've got the Project Firstline team behind the scenes here to answer any questions you might have as we move along. And feel free to reach out if there's any way we can help support you in your IPC efforts. Thanks for being here.
And thank you, Dr. Kearney and the team, for being here in support of this webinar. My name is Stephanie Doyle. I'm an infection prevention training liaison for Project Firstline Rhode Island and a consultant public health nurse at the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. I'm your host and presenter today. I'm here to present Clostridioides difficile infections and how to prevent those infections in a healthcare setting. The goal is to help you understand the importance of infection control and prevention to help keep our patients, ourselves, and our colleagues safe. This is a 60-minute refresher session. I just want to go over, take a moment to review our continuing education criteria for those of you who are attending to receive continuing nursing education credit. So this is a 60-minute session that is approved as a nursing continuing professional development activity by the Northeast Multi-State Division Education Unit, accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. So in order to receive your CNE credit, you must complete the pre-session survey, attend this live training, complete a post-session survey, and then complete a post-session quiz. If you are not looking to receive continuing nursing education and just a certificate of training, you will not need to fill out the post-session quiz. So just the first 3 are required for a certificate of training. If you have any questions regarding this, feel free to reach out to us. Just a couple of housekeeping reminders. You have seen the chat where our survey is posted. Abby, who is our Project Firstline project assistant, will be posting information for you in the chat throughout the webinar. Thank you, Abby, for being here and helping out behind the scenes. And if you would like to take a minute, go ahead and introduce yourselves in the chat. Tell us where you're coming in from and your name. I'm so glad to see everyone here today. If you're joining us for the first time, welcome. And thank you if you're a returning guest. So happy to have everyone. If you would like to be added to our distribution list, which includes just reminders of our upcoming webinars and a monthly newsletter, go ahead and put your email in the chat as well. So on our agenda for today, we've done our welcome and our introductions. We're going to review learning objectives and talk about Clostridioides difficile, or C. diff, or C. difficile. We will define C. diff and review some C. diff data. We'll talk about the healthcare implications of C. diff, and we'll go into detail about infection prevention and control for C. diff infections, also known as CDI. We'll have some time to reflect and go over key takeaways. We have our announcements at the end. We'll ask for some feedback from you. Then if we have some time to answer some questions, we will do that. If not, you can always email us your questions and we can answer those via email as well. So at the end of today's session, you'll be able to define Clostridioides difficile infection and other key terms, identify who is at risk for infection, describe ways you can prevent illness by recognizing risks and identifying where germs live, identify pathways that C. diff can spread, learn infection control actions proven to prevent the spread of CDI, apply knowledge to drive infection prevention in your workplace, and empower others to strive for high standards of care when dealing with infection prevention and control in a healthcare setting. So the CDC, Center for Disease Control and Prevention, has designated Clostridioides difficile as an urgent global threat, calling it immediate, calling it an immediate public health threat that requires urgent and aggressive action. So C. diff is considered an epidemiologically important pathogen, which means it is an infectious agent that has one or more of the following characteristics: readily transmissible, have a tendency towards causing outbreaks, may be associated with severe outcome, or are difficult to treat. So in response to this urgent threat, the Antimicrobial Stewardship and Environmental Cleaning Task Force of Rhode Island, also referred to as AMSEC, has developed a C. diff playbook, which outlines an action plan to mitigate C. diff in our community. So the following are guiding principles they have outlined to guide efforts within the healthcare system as a whole in Rhode Island to help reduce the incidence of CDI. So these are the guiding principles, but also Abby does have a link to the C. diff playbook if you'd like to look at this a little bit further in more detail. So I'll just go over those briefly. The guiding principles are consistency, prevention, minimizing morbidity and mortality, and then minimizing costs. Abby has that reference there for you if you'd like to check that out in more detail. And I just wanted to outline a few key terms that you might hear throughout the presentation. And these definitions will be available to you in your post-session resources that will be emailed out after the presentation. I will explain these a little bit further as we go into detail about each one throughout the presentation. So just briefly about healthcare-associated infections before we narrow down to C. diff specifically. Healthcare-associated infections, or HAIs, are infections resulting from complications of healthcare. They are linked with high morbidity and mortality. And on any given day, 1 in 31 hospital patients has an HAI. Additional infections occur in other healthcare settings besides hospitals. Many HAIs are caused by the most serious antibiotic-resistant bacteria and can lead to sepsis or death. They can happen in any healthcare facility, including hospitals, ambulatory surgical centers, end-stage renal disease facilities, and long-term care facilities. Bacteria, fungi, viruses, or other less common pathogens can cause healthcare-associated infections. And the U.S. Department of Health and Human Services has identified the reduction of HAIs as an agency priority goal. HHS is committed to reducing the national rate of HAIs. Now we'll talk about our HAI of concern today, C. diff, and learn a little bit more about the bacteria. So what is Clostridioides difficile? The technical definition is that it's a spore-forming germ bacterium that causes severe watery diarrhea and colitis, which is an inflammation of the colon. It's formally known as Clostridium difficile and often called C. diff or C. difficile. It is a gram-positive rod, which is spore-forming. It's the most common cause of antibiotic-associated diarrhea illness. It causes symptoms which may be life-threatening and it can colonize in the gut. And as I mentioned previously, it is a pathogen bacteria of epidemiological importance. It is often a healthcare-associated infection, but it can also be community-acquired. So I mentioned spore forming. Let's talk a little bit more about spores. So C. diff is a spore-forming, gram-positive anaerobic bacillus that produces toxins. Common toxins found are toxin A and toxin B. And these toxins act on the lining of the colon to create a complex bodily response, including fluid secretion, inflammation, and tissue damage, which fits the clinical picture and are key features of C. diff infection. So when C. diff germs are outside the body, they become spores. Contamination and survival of C. diff spores on hospital surfaces or healthcare surfaces have been reported and shown to be associated with spread through indirect transmission, which means the transfer of a germ from a reservoir where the germ lives to a person by objects or surfaces in the environment. So these spores are an inactive form of the germ and have a protective coating allowing them to live for months on surfaces and in soil. And these germs become active again when these spores are swallowed and reach the gut. So time for our first poll question. So how long have C. diff spores been proven to live on surfaces? So you should see that pop up on your screen there. How long have C. diff spores been proven to live on surfaces? A, 24 hours, B, up to 7 days, C, up to 5 months, or D, 1 year. Go ahead and fill in that poll there. All right, so we have 77% of you said up to 5 months, and that is correct. So according to the Journal of Microbiology article titled Detecting Clostridioides difficile Spores in Inanimate Surfaces of the Hospital Environment, which method is best, C. diff spores can be shed to the environment by both asymptomatic and symptomatic patients and may survive for up to 5 months on inanimate surfaces. They resist the bactericidal effects of most hospital disinfectant and most other decontamination techniques. Very good. Thank you for your participation in that poll question. Very good job. So as I mentioned previously, C. diff is considered by the CDC an urgent public health threat. While healthcare-associated C. diff cases have decreased some, community-associated cases have not. So why do we care about C. diff as a healthcare-associated infection? It is a major cause of death and increased morbidity in hospitalized patients worldwide. CDI are more common and tend to be more severe in older patients who may have other serious health conditions. Healthcare settings can act as amplifiers of infection. Healthcare spread has often been an important contributor to the extension of outbreaks, which pose a significant economic burden. So now I'm going to review just some myths and facts about C. diff that you might have heard across your time in the healthcare field. So our first myth versus fact: alcohol-based hand sanitizer and soap kill C. diff spores. So that is a myth, when in fact, C. diff spores, while hand hygiene with soap or alcohol-based hand sanitizer may remove C. diff spores, it does not kill them. Current evidence demonstrates that C. diff spores may not be fully removed from the hands, regardless of the method used to clean hands. This further emphasizes the need for appropriate use of gloves for the care of patients with CDI. Alcohol-based hand sanitizers are highly effective against non-spore-forming organisms. They do not kill C. diff spores. Our next myth versus fact: CDI only occurs in hospitals, when in fact, approximately 45% of cases are community-acquired That is why it is so important to educate our patients who have been diagnosed with C. diff and be advocates for antimicrobial stewardship. And then lastly, a myth versus fact. Many cases of CDI can be prevented with evidence-based recommended infection control and prevention IPC strategies. And some cases of CDI may not be preventable, but we can certainly greatly reduce. So as we mentioned, CDI is the leading cause of antibiotic-associated diarrhea and one of the most common healthcare-associated infections in the United States. So the Emerging Infections Program for Healthcare-Associated Infections has a broad surveillance area where selected territories report cases based on case definition criteria. So this is some data that was collected back in 2020 regarding CDI. Much of the recent increase in the incidence and mortality of CDI is attributed to the emergence and spread of a hypervirulent resistant strain of C. diff that produces greater quantities of principal virulence toxins A and B and has additional factors enhancing its virulence. There for a minute so you can read through that. So the first step in stopping the spread of infection is identifying infection risk. When you are aware of who is at risk and how germs spread in healthcare, you can use your clinical knowledge and skills to impact decision making. Knowing how to recognize risk and take infection control actions, such as implementing transmission-based precautions, is key in preventing the spread of infection. If prevention does fail, and the patient who may be highly susceptible to infection becomes ill, there are proven actions we can take to help keep ourselves, our patients, and our families safe. Once illness is suspected, infection control actions, such as knowing when to test and isolate, can help mitigate the spread of illness. Written protocols can be helpful about outlining a process that has been proven effective in managing patients with suspected illness. Making these protocols transparent and accessible to all members of the care team, providing ample time for education and training, can establish an environment within the facility that focuses on infection control and prevention. Education that is clear and understood by everyone is vital to implementing actions that can reduce the spread of illness. Patients with a prior recent infection of CDI are likely to become ill again with the infection. Key actions to lower the incidence of CDI are follow-up and communication. Actions go beyond what is done on the front lines. A holistic approach to care involving all personnel involved in caring for the infected patient, including administrators, social workers, environmental services, pharmacy, can be an effective tool for reducing outbreaks and the spread of infection. These are key strategies that can be helpful in identifying and managing patients with CDI. Now we'll talk about who is at greatest risk for CDI and how they might present clinically in practice. So which patients that we take care of are at increased risk for CDI? Patients who are most vulnerable to CDI are those who have had a recent antibiotic exposure, those with an immune compromising condition such as cancer, or use a medication that impairs their immune system, such as long-term use of steroids or chemotherapy. Prior CDI can increase the risk of recurrent infection. Also increasing the risk is a recent stay or long stay in a healthcare facility, recent gastrointestinal surgery, serious underlying illness, or advancing age, or a combination of any of these risk factors. And even though advancing age is a risk factor, CDI affects patients across the lifespan. So how is this infection going to present clinically? Clinical manifestations of the infection caused by C. diff vary from asymptomatic to severe illness, depending on a wide range of factors. Patient may present with complaints of abdominal pain, watery diarrhea with mucus or blood, anorexia, nausea, vomiting, low-grade fever. The provider may assess abdominal tenderness and abdominal distension. Diagnostic studies may show inflammation of the colon or colitis, If symptoms are severe and left untreated, the patient may develop toxic megacolon, leading to peritonitis, bowel perforation, and even death. C. diff infections range from asymptomatic to severe and may require surgery and could lead to death. I just wanted to share some of these resources now that we've reviewed who is at risk and signs and symptoms to look for in patients. We have some valuable tools you can use to spread awareness. And Abby can post the link to these tools in the chat, and you'll receive those also in your post-session resources. So those are just some valuable resources that you can use to spread awareness. Who is at risk and how to prevent C. diff. And this is a C. diff fact sheet, an infographic for healthcare professionals, and it has some great information on prevention measures, who is at risk, how it spreads, and how to prevent C. diff in your facility. So how C. diff spreads and makes people sick. Time for our second poll question. And you'll see that pop up on your screen there. So prevention is key in reducing and eliminating CDI. So what can we do as healthcare professionals to prevent the spread of CDI? So A, be aware of what antibiotics your patient is prescribed. Know when to test for CDI. C, isolate patients as soon as possible. D, use proper PPE and perform hand hygiene before and after glove use. Or E, all of the above. Give you just a couple seconds there to answer that poll question. 100%. Very good. All of the above. Very good. So here we'll discuss and review the 5 elements of how germs spread and cause infection. So there are more pieces to the puzzle of germ spread than reservoirs and pathways. Germs also need to arrive at a new person, and that person could be a patient or you or one of your colleagues. And in order to infect them, the germs need to get around the person's natural defenses. And if the person is already sick, then their immune system could be weak and not able to fight germs as well as a healthy person's can. So throughout all of these elements, the germs need to survive or stay viable in the environment if they're going to make someone sick. The infection control actions that you take at any one of these points help keep germs from spreading and causing infection. So let's review this in a little more detail relative to C. diff infection. Germs need a pathway to be spread out of the reservoir where they live. Think about some reservoirs where C. diff could live. And if you'd like, put some reservoirs where C. diff could live. Put those in the chat there. Where do you think this bacteria could live? Some reservoirs. Think about where this germ lives. So it lives in the gut. Some reservoirs would be the gut, skin, the hands of healthcare workers. How about surfaces? What kind of environmental surfaces could this germ live on? Countertops, floors, tables. Good. Yep. So as you think about where the germ lives, also think about how the germ travels or what pathways it can get into the body. Did anyone think of any pathways that it could get into the body? Go ahead and share in the chat. The germs need to be delivered to a person and get around their body's defenses to infect them. Do you care for patients or residents who currently or have been recently taking antibiotics? They're likely ill with another infection, which may lower their body's defenses and make them more vulnerable to CDI. Those who are already ill or potentially already infected, lowering their defenses. Germs also need to survive in the environment while they spread to be able to cause an infection while they reach someone. C. diff spores can live on surfaces. We established that for very long periods of time. Infection control actions at any one of these key points can keep the germs from spreading. Good. Thank you for your participation there. Open wounds, hands, food, toilets, bedpans, all great reservoirs, pathways. Now that we've established some reservoirs and pathways, what are some infection control actions that we can take to reduce the risk of this bacteria from spreading? Hand washing. Gloves, I'm seeing PPE, hand washing. Disinfect surfaces. Excellent. Perfect. Gown and glove. Very good. Thank you. Thanks for participating. So how is CDI transmitted? C. diff is shed in feces, and C. diff spores can be transferred to patients via the hands of healthcare personnel who have touched a contaminated surface or item. Any high-touch surface or device that becomes contaminated with feces could serve as a reservoir for C. diff spores, which everyone participated. That was great. C. diff spores can be transferred to patients via these contaminated surfaces by the pathway touch, directly or indirectly. Devices such as blood pressure cuffs and commodes, bathtubs, handrails, and bedside tables, any surface, device, or material that becomes contaminated with feces could serve as a reservoir for these spores. So now that we've reviewed reservoirs and pathways and identified some infection control actions, let's go over a common scenario in healthcare. So let's take a look at this picture here. Here we have an ill patient and a healthcare professional providing medical care to this patient. So in this particular scenario, the healthcare professional did not perform hand hygiene after glove removal, after handling soiled linens, a patient with suspected C. diff. So C. diff spores are remaining on this healthcare professional's hands. They're now touching the IV pump. They could have potentially touched the patient. They could have touched the bed rail. So contaminating these environmental possibly shared equipment and environmental surfaces. So C. diff spores are now on the bed rail. From there, how could it get to the patient? As we mentioned, the worker's hands were contaminated first before touching the bed rail. The patient could pick up the germ on their hand when they touched the bed rail if it hadn't been cleaned and disinfected first. The patient could then pick up food with hands and eat it, delivering the germ to their body. The germ has survived because the bed rail was not cleaned and disinfected, and the patient's natural defenses can't fight it off. The patient now has an infection. Now, the way I just outlined the 5 elements in this example isn't the only way germ spread could happen. In fact, there are many ways that the elements could work in the scenario for an end result of the patient becoming infected. It's also important to remember that the elements that germs need in order to make someone sick aren't steps in an order, and it's not inevitable that someone will get sick from a germ. Infection control actions can keep germs from spreading at any point. The reservoir, pathway, new person to infect, their body's defenses, and the survival of the germ itself. So now we're going to get into infection prevention and control actions. So the first prevention action I'd like to talk about is standard precautions for the care of all patients in a healthcare setting. So as we know, standard precautions are used for all patient care based on risk assessment and make use of common sense practices and PPE use that protect healthcare workers from infection and prevent spread from patient to patient. Highlighted bullet points especially apply to the care of the patient with CDI. So I'll just review those briefly and then we'll get into detail about each. So hand hygiene as a standard precaution. Before and after glove use is recommended in the care of the patient with CDI. Use of personal protective equipment or PPE. Wear gloves when there's potential contact with diarrhea. Do not wear the same pair of gloves for the care of more than one patient. And wear mouth, nose, and eye protection during procedures that are likely to generate splashes or spattering of body fluids. So cleaning and disinfecting environmental surfaces as standard precautions. Objects such as monitors, IV pumps, door handles, bed rails, um, should be cleaned before and after use. Utilize disposable equipment as much as possible. Disinfect any shared equipment such as computer screens, keyboards, phones, call lights, light switches. Make sure you're identifying high-touch surfaces and cleaning and disinfecting those as appropriate. Then healthcare laundry. When you dispose of soiled linens, they should be placed in the proper receptacle. When carrying these items to the dirty linens, keep them away from your body. Strip and handle linens in a manner which avoids shaking that may suspend spores in the air. And then waste management. Any waste that is produced from a procedure must be disposed of properly. And you want to make sure saturated materials end up in medical waste bags as per your facility policy. Standard precautions are frequently where healthcare workers can get complacent. We are very busy, so the extra few minutes to perform hand hygiene thoroughly or donning the appropriate PPE can seem time-consuming, but these are the small things that can make a huge difference. So as healthcare personnel, we have an obligation to our patients and our residents, coworkers, our families, and ourselves to maintain standard precautions for infection control while caring for our patients' residents to help keep everyone safe. There are several measures, including performing hand hygiene, that should be applied to prevent and control C. diff infection. The following is a brief description of these key steps, which should be in place when C. diff infection is present. Patients should be placed in isolation when infectious diarrhea is present, and at least for the duration of their illness. Hand hygiene, unless hands are visibly soiled, alcohol-based hand sanitizer is preferred over soap and water in most clinical situations because it is more effective at killing germs on the hands than soap. It's easier to use when providing care, especially when moving from soiled to clean activities on the same patient, or when moving between care of patients in shared rooms. Results in improved skin condition with less irritation and dryness than soap and water. Improves hand hygiene adherence. But it is also key to remember when to wash hands with soap and water. So when are you going to wash your hands with soap and water? When hands are visibly soiled, before eating, after using the restroom, but during the care of patients with suspected or confirmed infection during outbreaks of C. diff and other highly infectious GI illness with potentially infectious diarrhea such as norovirus. Contact precautions should be initiated once infectious diarrhea is suspected. Healthcare workers should wear gloves and gowns when providing care for patients with C. diff and should discard them immediately after they have been worn for patient care activity. There is evidence that wearing gloves significantly reduces CDI and is therefore crucial, but hands can become contaminated even with correct glove usage. And remember, gloves are not a substitute for hand hygiene. And patients with CDI should have their surroundings and other areas of concern, such as toilet areas, commodes, high-touch surfaces, cleaned at least daily using clean equipment and a product approved by the Environmental Protection Agency, or the EPA, verified product. Remember to be aware of what products are being used in your facility and their contact time recommended for killing spores formed C. diff contamination. Only hospital surface disinfected listed on EPA's List K are registered as effective against C. diff, and we'll look at that a little bit more detail later. Now I'll go into a little bit more detail regarding hand hygiene. I do have this short video that I'll play for you now from the CDC's Clean Hands Count campaign. So I'll play that. It might not move right away, but it will. You will hear it, but it will move eventually. Here we go.
We all know about the growing threat of antimicrobial resistance. and have seen the headlines about superbugs and nightmare bacteria. Unfortunately, this threat is very real. Now more than ever, it's critical that we work together to contain these drug-resistant pathogens and the infections they cause. Keeping our hands clean is one of the most important ways to prevent the spread of infections. Every time we enter the patient zone, we can get dangerous germs on our hands and spread them to ourselves or to other patients. Sometimes we don't clean our hands as often as we should, not because we mean to do harm, but because it's a daunting task. Some of us might have to do it 100 times a day. It takes dedication, mindfulness, and time. Our patients' lives depend on it. Let's applaud the efforts and improvements we've already made. Increases in hand hygiene adherence have led to decreases in healthcare-associated infections. At the same time, we know there is still room for improvement. We can all do better. Our clean hands count. Now, more than ever.
And this is a nice little infographic too that you can post in your facilities. If you're interested, that will be available in your post-session resources. So healthcare workers' hands have been identified as a reservoir for C. diff. That is why hand hygiene is so important when caring for our patients or residents in a healthcare setting. Hand hygiene should be performed before and after any care activities. Like we identified earlier, C. diff is a spore-forming bacteria, and spores can live on healthcare workers' hands and patients' hands for long periods of time. Hand hygiene is vital when caring for patients with known C. diff. Alcohol-based hand sanitizer or soap does not kill the spores, but the friction of performing hand hygiene using soap and water for hand washing washes away the spores, therefore reducing the risk of spreading CDI to yourself or others. The proper glove use, including correct donning and doffing, is also key in stopping the spread of CDI. Gloves should be always worn when caring for someone with suspected or known infection. So as we mentioned several times, C. diff is a spore-forming bacterium that can lead to common HAIs, causing severe diarrhea. And spores are an inactive form of the germ that have a protective coating, allowing them to live on surfaces for months. So unless hands are visibly soiled, alcohol-based hand sanitizer is preferred over soap and water for cleaning hands in most clinical situations. This recommendation does not vary when caring for patients with C. diff infection. Although there is a theoretical advantage to cleaning hands with soap and water when caring for patients with CDI, CDC still indicates a preference for alcohol-based hand sanitizer. Studies have not shown a clear prevention benefit for soap and water, and removing alcohol-based hand sanitizer risks reducing hand hygiene compliance overall. So when entering the room of a patient with C. diff, the priority should be to ensure glove use, in addition to a gown, and proper technique when removing gloves to minimize the risk of self-contamination. Current evidence demonstrates that C. diff spores may not be fully removed from hands regardless of the method used to clean them. This further emphasizes the need for appropriate use of gloves for the care of patients with CDI. As an additional precaution during outbreaks of C. diff, CDC encourages hand washing with soap and water after the care of patients with known or suspected infections. This is recommended due to the theoretical increased efficacy of soap and water for removing spores from hands, although evidence for this recommendation is limited. Proper use of gloves in addition to a gown to reduce bioburden on the hands should be emphasized. And access to alcohol-based hand sanitizer should not be restricted. C. diff and hand hygiene studies, although use of alcohol-based hand sanitizer is ineffective at removing or disinfecting C. diff spores in controlled laboratory experiments, clinical studies have not demonstrated an increase in CDI with the use of alcohol-based hand sanitizer products or a decrease in CDI with the use of soap and water. So a couple of interactive questions here for you. I'll ask for your participation here. If you want to answer in the chat, yes or no. Should we remove alcohol-based hand sanitizer from areas where there is CDI? Excellent. The answer is no. Alcohol-based hand sanitizer is required at the point of care for a number of reasons. They're easy to use and therefore more likely to result in greater compliance with the need for hand hygiene by healthcare professionals. They are proven to be effective in killing a range of pathogens and therefore reducing patients' risk of acquiring healthcare-associated infection. They are effective in killing the non-spore form of C. diff, which may present in higher numbers than the spores. And sinks for hand hygiene are not always readily available, and even if they were made available right next to a patient, washing takes at least twice as much time than rubbing. All factors that mitigate against full compliance with hand hygiene. Relying on promoting hand washing only in healthcare is thought to result in lower compliance, lower efficacy, and greater risk of continued spread of pathogens. And evidence-based research reinforces the need for the presence of alcohol-based hand sanitizer to ensure maximum patient safety. And there is no evidence to suggest that their use has been connected with increased C. diff infection. So our next question. Does the promotion of alcohol-based hand sanitizer imply the downgrading of sinks and hand washing with soap and water? So correct. The answer is no. Guidance usually highlights the fact that hand washing is essential in specific situations, as described above. Although washing hands with soap and water remains an accepted method for routine hand antisepsis, alcohol-based hand sanitizer should be promoted as the gold standard for hand hygiene, considering in particular their dramatic impact on improving compliance with hand hygiene and ensuring clean, safe hands. Now we'll talk about transmission-based precautions, contact precautions for C. diff infection. So if a patient has had greater than or equal to 3 stools in 24 hours, isolate immediately and initiate contact precautions, even if C. diff infection is only suspected. These patients or residents should be placed in private rooms. If private rooms are not available, they can be placed in rooms with other patients with CDI, also known as cohorting. And cohorting should be considered in conjunction with a risk assessment and infection control expertise. And follow evidence-based protocols for removal of isolation precautions. Because patients with CDI continue to shed the organism for several days following the end of diarrhea, some institutions routinely continue isolation and contact for either several days beyond symptom resolution or until they are discharged from the facility, depending upon the type of setting and average length of stay. It's important to know and follow your institution policy, which may have more stringent guidelines. And we do have a link to that signage that will be available in your post-session resources if you're interested in using that sign. So use contact precautions for patients with known or suspected CDI, which includes use of gowns and gloves before entering the room and during the care of a patient resident with or suspected of having CDI. Use dedicated patient care equipment whenever possible. If not possible, use an EPA List K disinfectant immediately after each use. We want to make sure we're communicating precaution status to direct caregivers and other key staff members, including environmental services, dietary, therapy, social work, activity staff, and discontinue precautions when diarrhea has resolved. And some experts recommend continuing contact precautions, which I did mention. Just make sure you're following your facility policy. And you may want, they may want to also consider continuing contact precautions through completion of antibiotic therapy for C. diff infections. In facilities with high rates of CDI, consider continuing until discharge. The colonization with C. diff is more common than infection. Colonized patients do not have disease caused by C. diff and often exhibit no clinical symptoms, making them asymptomatic. Colonized patients do still test positive for C. diff organism or its toxins. Patients with infection exhibit clinical symptoms and test positive for C. diff organism or its toxins. Here, I just wanted to share this clinical practice tool for testing of C. diff for your patients, residents, but I just want you to remember to refer to and be familiar with your laboratory's guidelines for testing and your provider's recommendations. So you're going to assess your patient or resident for appropriateness of testing, consider other infectious or non-infectious causes of diarrhea before testing for CDI, discontinue laxatives, and wait for at least 48 hours before testing if still symptomatic. Once a patient has a positive CDI test, do not repeat testing to detect cure. Test may be positive for up to 6 weeks after infection is resolved. And tests for CDI should never be ordered for formed stool. So it shows the Bristol stool chart there on which types that can be tested for C. diff. So in your facilities, consider use of a standardized criteria for CDI testing. Be familiar with your lab requirements. Some labs will even reject the samples if criteria is not met. For example, the lab may not accept a specimen that is not entirely liquid, or if the patient resident had used laxatives in the last 24 to 48 hours. And we can share a link to this tool if it's something that you're interested in using or putting in place something similar. And for our third poll question, you'll see that pop up there. When can a patient with C. diff infection be removed from contact precautions? So A, never. Patient should remain on contact precautions indefinitely. B, if the patient is feeling better with only 1 watery stool a day. C, CDI does not require contact precautions or isolation. Or D, for the duration of illness. All right, look at the answers coming in. So we have 90% of you said for the duration of illness, which is correct. Although your facility policy may differ, according to Appendix A, type and duration of precautions recommended for selected infections and conditions, guidelines for isolation precautions in a healthcare setting for gastroenteritis from CDI, contact and standard precautions should remain for the duration of illness. And refer to your facility policy to see what is required in the criteria for removing patients from isolation. Very good. Thank you for participating in that final poll question. And we're now talking about cleaning and disinfection. So cleaning and disinfection for residents, patients with C. diff infection. So we want to make sure that communicate to all staff involved in the care of the patient or resident in cleaning and disinfection the isolation status of the patient with CDI, read labels clearly to ensure products are effective against spores, and that they are on List K from the Environmental Protection Agency list for recommended products that kill C. diff spores. And make sure all staff know who is responsible for cleaning and disinfecting in the care of the patient with CDI. It may be helpful to create daily and terminal cleaning protocols and checklists for patient care areas and equipment. Perform daily cleaning of rooms using C. diff sporicidal agent. Clean and infect the environment, including the immediate vicinity around the patient and resident, and identify high-touch surfaces to be cleaned at least once a day, including commodes, toilets, bedside tables. Clean and disinfect all shared equipment prior to use with another patient, including lifts, wheelchairs, canes, walkers, anything that can be shared. And perform terminal cleaning after the patient or resident with CDI is transferred or discharged with sporicidal agent. And this is just an example of the EPA registration list K. You want to make sure that all of your disinfectants that you're using are approved for use against the C. diff spores. And we will be sharing a link to this website where you can check if your products are effective against C. diff. So List K products are registered for use against C. diff spores, and EPA has reviewed required laboratory testing data demonstrating that these products kill the spores of C. diff. So a product's effectiveness can change depending on how you use it. Disinfectants may have different directions for different pathogens. So follow the label directions and then make sure that your staff understands how to read the label and how to follow the label and make sure that they are using the correct product for the organism. And finally, for our infection control actions, antimicrobial stewardship. More than 2.8 million antimicrobial resistant infections occur in the United States each year, and more than 35,000 people die as a result. Ensuring appropriate use of antibiotics is one of CDC's core strategies to combat the threat of antimicrobial resistance. Antibiotic stewardship is also important to ensure equitable access to high-quality healthcare and to optimize treatment of infections and promote safety. And why is it important? As healthcare personnel, we must advocate for the best outcomes for our patients. Gaining knowledge about antimicrobial stewardship can empower us to encourage prescribers to make informed decisions about treatment options, especially for those who are most at risk for CDI. Antibiotics have transformed the practice of medicine, making once lethal infections readily treatable and making other medical advances like cancer chemotherapy and organ transplants possible. Prompt initiation of antibiotics to treat infections reduces morbidity and saves lives, for example, in cases of sepsis. However, about 30% of all antibiotics prescribed in the U.S. acute care hospitals are either unnecessary or suboptimal. And like all medications, antibiotics have serious adverse effects, which occur in roughly 20% of hospitalized patients who receive them. Patients who are unnecessarily exposed to antibiotics are placed at risk for these adverse events with no benefits. Misuse of antibiotics has also contributed to antibiotic resistance, which is also a serious public health threat. And the misuse of antibiotics can adversely impact the health of patients who are not even exposed to them through the spread of resistant organisms and C. diff. All right, we made it. So our key takeaways: CDI is an urgent public health threat, but it can be prevented. It's the leading cause of healthcare-associated infection. Proven practices, when implemented, can reduce the burden on patients and healthcare professionals. And with IPC practices like identifying who is at risk, implementing core ICP practices, and antimicrobial stewardship, we as healthcare personnel can reduce incidences of CDI. So here are our resources. That you can find us on social media, and you can look at our website there and sign up for our upcoming webinars and our future training sessions. I'll be presenting our fifth and final, could be our final, we could have one more, preventing healthcare-associated infections, surgical site infections on April 7th. Then on April 21st, my colleague Jacob Peguera will be presenting blood, a quick refresher, on April 21st at noon. And Abby is putting the link to register there in the chat. And here are our references for today's session, and you'll be emailed those in a couple of days, along with our post-session survey and our quiz. So make sure you remember to complete the requirements if you would like to receive continuing nursing education for today's event. Please fill out our post-session survey and the post-session quiz, and your certificate will be emailed out to you. And now we just have well, 1 minute left. If you'd like to just fill out our end of session feedback poll. If you have any questions, please feel free to email us. We do have about 30 seconds if anyone has anything pressing that they want to ask.
Hey, Steph.
But if you, go ahead.
We've got 2 questions that came up already in the chat. I think I just saw a few more that we probably won't have a chance to get to, but I did want to address 2 that I saw come through. The first one was about why does the use of antibiotic increase your CDI risk? And that's because antibiotics don't know the difference between good bacteria and bad bacteria in our gut, right? You're taking an antibiotic to treat an infection on your foot. That antibiotic is going to try to kill all of the different germs that it can within its scope. And so it might get rid of some good bacteria in your gut as well as the bad, allowing the C. difficile strain in your gut to reproduce. So your C. diff infection risk goes up with not only the use of antibiotics, but the cumulative dose, the cumulative number of days, cumulative number of types of antibiotics that you are taking. And then there was another question I saw come through about UV light, UVC. So UVC, I would say a few things. Caveat being, you got to look at the manufacturer's recommendations for that specific light that you're using to see if what spectrum it is, if it is designed to kill C. diff spores. Per the CDC, the use of ultraviolet light can be considered as a supplemental intervention for C. diff cleaning and disinfection, but is not currently one of the highest recommendations. It's in their supplemental options that you could consider, but I would really look at the manufacturer's guidelines for the specific light that you're thinking about. There were other questions. We'll follow up on email with those. Back to you, Steph.
Thank you so much, Dr. Kearney. Great session. Thank you so much for your participation. And like Dr. Kearney mentioned, we will definitely get to all of your questions. It's great to have you interact with us. And thank you so much for taking the time to join us. And we hope to see you again in the future. And happy Monday and have a great day.